the question that every resuscitationist wants to know, and that is about epinephrine.
It hasn't changed.
I know, it hasn't changed.
Okay, just making sure.
I think that is the concern. So there are some studies that are suggesting that our standard epinephrine, 1 milligram every 3 to 5 minutes, even though it improves ROSC, it might worsen neurological outcomes. And the guidelines...
Oh, Paramedic 2 said that flat out.
Right. And the guidelines didn't change the dose or frequency. I thought something might be modified with the new guidelines, but it's exactly the same as it's been. So I'm just curious what happened behind the scenes, how we came to that decision.
Well, I guess the question is, what evidence?
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
You may have heard that the AHA just released their new resuscitation guidelines October 22nd, and I have been looking forward to this AHA guideline update for a long time. Every time new resuscitation guidelines come out, it's an opportunity for all of us, especially those of us who love resuscitation science and have worked hard to hone our resuscitation skills. It's a time for us to reflect, to recalibrate, to make sure we're delivering care that's truly evidence-based. And I'll be honest, when I first read through the new guidelines, I was really excited about several of the updates. Like the language is clearer, the algorithms are easier to follow, the emphasis on post-resuscitation care feels more in line with what we're seeing at the bedside. But there's also a few things that really surprised me. And honestly, some that felt a little controversial. And I just knew they were going to get debate and backlash. So today, I am thrilled to be joined by the man himself, Dr. Ashish Panchal. He is the chair of the American Heart Association Emergency Cardiovascular Care Committee. You may remember him from episode 140, where he talked about how resuscitation science has changed through the years. He's literally the head of the group of experts who came together to review the literature and create these guidelines. He's here to help us unpack what's new, why the committee made certain decisions, and how these changes will impact the way we practice at the bedside tomorrow. So Ash, welcome back to the Rapid Response RN podcast.
Hey, it's my pleasure. It's great to be here.
Oh, it's so good to have you. So just real quick, you wanted to give an introduction about your history, why you love this stuff. How did you end up as the head of this committee?
Oh, yeah. Well, yeah, so it's a long history, obviously, just the work you do. So I did my PhD in cardiac physiology at Case Western when I first started. This is before even I went to medical school. And so I was always been a cardiac physiologist. And from there, as I did my medical school and I did emergency medicine, I became a resuscitationist at heart. And I actually went to the University of Arizona as faculty for my first job where I met Carl Kern, Bob Berg, Dan Spade, Ben Bobrow. These are all resuscitation giants, right? And I went there literally to become a resuscitationist, to learn how to do this stuff. And it was the best part of my life because it was like, that's all I did. All I did was learn about resuscitation from these people who like are so much smarter than me and to this day are my mentors. And at one point they just said, okay, it's time to fly and be free. I moved to Columbus and I've continued my resuscitation work. And I started with the AHA back in 2013 and I've continued with that throughout the time. I've been on, a lot of guidelines. First author for 18, 19, 20, and I have a couple of chapters in this one too. So this has been a big part of my life. I enjoy it. I'll be honest, the best part of it is the volunteers. The very fact that this is volunteer driven is so powerful for me. And the fact that you meet all these international experts. So the AHA guidelines aren't just ours. It is international pieces tossing into the mix too. So it's a great experience through that process.
Oh, well, I am so glad to have all your expertise here with me on my podcast. Before we dig into the actual updates, I think it's important for listeners to understand like how these guidelines came to be. I mean, when we read them, it looks so polished and definitive, but I know there's an enormous amount of science and debate behind each line and each word that you guys selected. Can you walk us through how the AHA Resuscitation Committee reviews the literature and decides whether something warrants actual practice change or guideline change?
Right. So the crazy part that most people don't realize is pretty much when 2020 was done. When we put 2020 out in November of 2019 and it came out as the new set of guidelines, work on 2025 started. This is a 5-year process of continual evidence evaluation to understand what's going on out there, right? And so it's not only the process of what we do as an AHA guideline committee, it's also what gets pushed into the work that ILCOR does. That's the International Liaison Consortium for Resuscitation. So this is an international group whose whole focus is to do evidence evaluation and to look at the data which is there. Now, you're going to see a lot in this AHA guideline where we say, from the ILCOR review. Why is that? Because there are members of the American Heart Association who are from North America who are part of ILCOR. ILCOR is the international group which actually looks at that data together. Right? And then what we do is we take that information after it's been processed and understood and grade systematically reviewed so everyone knows what this means, and then takes public comment. So there is a public comment phase, and then takes that and puts it into what we think is most appropriate for North America, right? Because let's be honest, it's very different what's happening in Paris than it's happening in Columbus, Ohio. It just is, right?
Yeah, different patient populations and so many factors.
All those things. I mean, the very fact that I can get someone out of a building in Ohio versus having to stay in the Louvre and resuscitate them, right? We've all seen that picture, which is unbelievable, right? Doing ECMO in the Louvre, right? So with that being said, the review process that we do at the AHA starts with, of course, this large evidence evaluation. From there, as the evidence is evaluated, now's the fun part. Now's the part where we actually sit down and start looking at that evidence evaluation and trying to understand, is this really applicable for our population? What does it really mean? Why is it the case? And the way we go about it is actually going back to the original literature, pulling all those papers, reading those papers as a group of a committee, and arguing about what the implications are. And when we say implications, it's not the conclusion of the paper. It's actually looking at the numbers, the methodology. How did they do this? Can we trust this? Where are the ramifications? And then we talk about implementation. So you go all the way from data to implementation and how that's going to happen in our society. So it's a huge process, but I'll be honest with you, it is some of the most satisfying times for me, because imagine getting a bunch of your nerdy friends together and arguing about a resuscitation topic. It's a bit of my dream because I'm a nerd, but hey, it's all good.
I mean, if there's snacks there, plus that, that's like my kind of day right there. That sounds like a blast.
And lots of caffeine.
Lots of caffeine, I'm sure. Okay, so let's start with some of the updates that caught my attention, like in a good way. There's been a lot of refinement in the way the guidelines are written this year with clearer verbiage. The algorithms are a little bit clearer. The bedside decision-making is definitely straightforward. I really appreciate how it's been distilled down. I love the new update. Can you share just like big picture updates? What are some improvements the committee was focused on this cycle?
Yeah, I think one of the biggest things that's like starting from the basics, I think one of the fundamental things that you see, and it comes out in the system of care, is the unified system of care that we have, the chain of survival, right? So really think about that unified chain of survival. And why is that important, right? So this is finally getting to the point that we're all singing out the same music, right? Before we had a system of care for out of hospital, in hospital, peds, adult, and now we're on the same music, right? And here's the cool part about that music. So the cool part is it really highlights the key role that our lay rescuer really has in all this. And notice I said lay rescuer. I'm not using bystander.
Yes, I love that verbiage.
Yes. It's so important, right? I mean, I would love to say tri-standard, but like even that is a little corny. But the lay rescuer, the critical part they have at the first 3 steps of our chain of survival was not nearly as hammered in. And this time it makes it really consistent for us to be saying, here's our chain of survival. And you as a lay rescuer, your job is those first 3 chains, right? Your job is to activate the emergency response, do high quality CPR, and get an AED. Those 3 things is your job, right? And it makes the training for that population easier and really gives us a strong focus there, right? So for me, that's one of the big things. The other big thing I think is across the guidelines, you see cleaning up. You see lots and lots of cleaning up of old things that were there anecdotally and really thinking about, okay, what is really the best approach here? And that really was a great piece to move forward. Now, the other big thing that we really need to think about is from the lay rescuer perspective. So we go all the way from the lay rescuer to the healthcare professional throughout the guidelines, right? And we know from the healthcare professionals, there are certain things that are going to move the needle for us, but it's really the lay rescuer who really makes the difference in a lot of these cases, right? And so for them, some of the key concepts are really, of course, the engagement piece and keeping hands-only CPR simple and straightforward, and that's still a feature. The choking is huge, right? The change in choking is enormous because we actually have a fairly good study, which is actually giving us some real guidance. And the last but not least, I think one of the coolest parts is in basic life support algorithm. It's actually kind of just snuck in there is we integrated opioid response throughout all the guidelines when it comes to that concept. It used to be a separate special circumstances in 2020, but now it's integrated, reflecting the fact that there's a huge problem with the epidemic, right? And I think those things are some of the biggest things that I can take away as like a global overarching conceptual framework. And that would probably be where I'd start.
Okay, I love it.
But of course, I'm an adult guy, so a lot of it's adulty.
Can we just go back to choking really quick? For those that haven't read the guidelines, what is the update with choking?
Yeah, so this, I think for me, this is one of my favorite things. There's a study done by Dunn in 24, I believe. And what they did is they did something very simple. They identified 700 patients who had severe foreign body airway obstruction. And they asked a simple question, and they went through all these charts and did unbelievable work to identify how did it get dislodged? Was it back blows, abdominal thrusts? What was the deal here, right? And the data was actually unbelievably shocking that the odds ratio with back blow as the referent, the odds ratio of abdominal thrust was 0.5, meaning it was 48% less likely for the first time to get that foreign body removed from the space. So the guidelines now reflect this data, right? So how does it reflect the data? 5 back blows followed by 5 abdominal thrusts for adults and children. Here's a caveat though, infants. Infants are 5 back blows followed by 5 chest thrusts with the heel of your hand because we want to protect the vulnerable abdomens of those beautiful little infants, right? So this is a significant change. We're moving away from anecdotal Heimlich maneuvers to actual real data, and the data is dramatic. It's scary dramatic, right? But the funny thing is, it's also more reasonable, right? So if somebody's choking in front of you, half the time, what do? We start slapping them on the back. That's what we do, right?
Almost like instinctive, yeah.
It is. And there's a reason for that. So one of the things that we have to think about is how do you implement these kind of things? And it seems like something that can be implemented easily and follows along with the data. That makes it exciting.
Yeah, that is exciting. Okay, what about synchronized cardioversion? There's been a little update. I like to call it go big or go home. What's the change there?
Yeah, so when we're thinking about our general concept of cardioversion, a couple of different concerns come in mind, right? So the first concern that we've always had is, and I want to tie this in because it's another one of the highlights in the top 10 for adult, is we always have a concern about the concept that somebody has cardiovascular compromise or not, right? So that's been clarified across the guidelines that these are the characteristics that define cardiovascular compromise. That's important, right? Because once we decide somebody has cardiovascular compromise of any type, we're going to go towards cardioversion, right? And we literally went, and I love that Michael Kurz on the webinar said, go big or go home, because that's literally the concept here. Because what there is data that at lower doses for cardioversion, you could actually cause problems. And you can go into irregular rhythms that you don't want to be in, like VFib, right? We don't want to go down that road. So the go big with go home concept is really sort of featuring the idea that if you want to reset and you're really doing a reset, give enough joules such that you actually do the job and get it done in a strong manner. Now, it also reflects, and it's not written in there, for me, it reflects the other additional concept that, let's be honest, the conceptual framework of drug delivery and drug success versus cardioversion success. We don't talk about this because there's not a study which looks at this. But I think we all know innately that if I give amiodarone, does it always work? If that person's hypotensive and dumping, and now I give amiodarone and now they get even more hypotensive, I think that's a bad outcome, right? So if we put this in a conceptual framework against someone who gets cardioverted, we know the safety profile of cardioversion is pretty darn good, especially at higher doses. So it really gives you the idea that there's other deeper ways we can look at this. And I'm already thinking in my head, okay, I got to do a study here. I got to do a study of failed drug versus cardioversion. That would be the cool study for someone with cardiovascular compromise, because it really hits the concept that high dose is going to be really powerful.
Yeah. I mean, how many times the drug failed and that's how we had to the cardioversion? There's so many times where you're like on the edge, like, oh, how unstable are they? Can we try the drug first? Should we just go straight to cardioversion? I remember learning as a new nurse, like the patient probably prefers that you do medications first over cardioversion.
And truthfully, are we doing them a favor, not cardioverting them? I mean, I think that's my issue, is that it's more me, it's more my barriers, it's more my fear than it might be what's best for the patient. I don't know the answer there.
The other thing I loved about the update is there's a lot of focus on the post-resuscitation care. Like once we got ROSC, now what? It's not just like the chain is done. There's more to be done. Yeah. What are some of the improvements and things that are highlighted in this new guideline for post-ROSC care?
Yeah, so Karen Hirsch was one of our leaders on that side of the guidelines, and they did an amazing job with post-arrest care. I mean, we set it up in 2020 where we had the two phases. We had the initial management phase, followed by the second, which is the continuing management phase, right? And the initial management phase is still pretty similar to what you would expect. Do airway management, manage the ventilation and oxygenation, manage hemodynamics, get that 12-lead EKG, decide on emergent coronary angiography. Notice I said the word emergent coronary angiography. We have RCTs to help us support those concepts, right? From there, as they went into continuing management, and asked the very fundamental question that if I'm not doing any drugs, and if I have nothing else on board, and they're not following commands, what do I do, right? And it really goes into the concept of not targeted temperature management, but temperature control. It brings in all that nice new data that we have about prevention of fever. Now, keep in mind, in 2020, we were all about targeted temperature management, and we had to put a focused update and alert out about temperature control, because when the new data came out, it was earth-shattering for us, because we're like, okay, it's prevention of fever now. And the best part of it is when they laid this out, they really started talking about the timing. And again, they pulled back from 2020, the multimodal approach, and we actually added light chain as another approach to actually start thinking about how you do neuroprognostication. So it pulled all those little snippets and those pieces together into this really strong, cohesive manner in which we look at this, especially looking at EEGs, giving a lot more details on seizures in the section itself. And it actually mirrors the Neurological Society's statement on post-arrest care and neurological. So it's great to see how these different pieces came together to form this cogent, cohesive piece. I think in the end, though, one of the things that is still going to be our responsibility that we have to own is, can we keep people in the realm of temperature control long enough so that we can actually do good neuroprognostication? Because we're still losing so many people because of poor neuroprognostication, early decision-making, all of that. And that's an important concept that we need to keep thinking about.
And a lot of that's a culture thing too. So
yes.
I hope that people can read these very clear guidelines and kind of shift the culture away from jumping the gun too early with that neuroprognostication. Okay, let's get into some of the juicy stuff.
Sure.
The parts that made me stop mid-paragraph and take a screenshot and send to my rapid response team saying, did you guys see this? There are some areas that continue to spark a lot of debate among providers. So let's just start with the big one, mechanical CPR. Many hospitals have invested heavily in these devices, but the data is kind of mixed. So what does the new guideline actually say? Because there's definitely some clickbait that makes it seem very dramatic. What does the guideline actually say, and why did the committee make this stance?
I'm going to start off by saying the guidelines didn't change since 2020.
I noticed.
So I'm going to start there. So take a second. If you happen to be one of those individuals who's really upset about this, I'm really sorry. But go back and look at 2020 real quick and see that things haven't really changed all that dramatically. I think one of the things that caught a lot of people is that it was actually in the top 10. That we very clearly said the routine use of mechanical CPR is not recommended, right? So where does that put us? Why is this the case? So one of the things that the original randomized control trials talked about and was seen in the original Hallstrom study was that there was some cases, number of cases actually, and in the trial with Hallstrom, that there was worsening neurological outcome in a bunch of patients. And this was mirrored in the paramedic trial, where you saw at early stage all the way to 30 days and out, you have worsening neurological outcome with mechanical CPR devices. Don't ask me why, because I don't know the answer. I mean, we suppose, and there's lots of suppositions about this. Is it the timing of how we apply the device, things like that, right? Lots of suppositions. And actually, one of my suppositions also is as the chest cavity becomes more and more soft, I think we've all experienced this, right? I think there's some variability in how we as humans do CPR. Now, the other thing to keep in mind, which is not part of this guideline, but I do want to toss out there for something for all of us to think about. This is also, a lot of these randomized controlled trials were in the age before pit crew and high performance CPR, as we do now, where we are so engaged in our teams, right? And pre-audiovisual feedback. If you are part of those shops who use audiovisual feedback like mine, there's no question in my shop that when my agency comes to a cardiac arrest, we are doing CPR, we're doing audiovisual feedback CPR, and we're looking at the results of that CPR, and we're looking at how well we did as a team, and we're giving direct feedback to ourselves. And that's how we know we're doing the best we can possibly do. Now, with all that being said, all anecdotal, all stuff that we're doing at my shop. But in these guidelines, we basically resupported what we said in 2020 that, hey, mechanical CPRs, there's signs there that there's something different and we don't know what those signs are and we need to be concerned about it, right? And one of the things that we have to think about though, especially with my agency, being an EMS guy, there are situations where you need to use it. When things are dangerous, and that guideline is sitting there waiting for you to use, right? And so for my agency, we have very clear protocols that when you first come on scene, if it's a safe and stable environment, feel free to do our normal full team press that we do with audiovisual feedback, all that kind of stuff. But if it's a dangerous space, if you're going to be going up and down stairs, things like that, get that mechanical CPR device out and you use it because you want you to be safe. And in my agency, we're a huge proponent of trying not to do CPR on the back of the rig. Now, one more thing that I need to tap in with this concept is one of the other comments, which are in BLS, I think it's number 1 on the top 10, is stay and play. We very clearly talk about the concept that if somebody has a cardiac arrest event, resuscitate them where they fall, right? And a lot of times when people are using mechanical CPR devices, they actually use it as part of a scoop and run type of pattern. So that's another thing that we have to keep in mind that we want to try to dissuade. But in the end, I think one of the big things is that number 1, it's not a huge change. Number 2, someone once told me, they said, this is the streets talking. This is the streets talking about mechanical CPR. And I kind of want to push back on that because I do really want to respect the great EMS clinicians who are part of these randomized control trials, put their heart and soul behind doing and being the people in these trials to make it happen. They are the streets. They're the ones who did the hard work to actually collect good data so we know what the data looks like, right? And so I think it's one of those balances that sometimes things don't feel right, but you know what? There's a lot of stuff that we've done in the past that felt right that we may have hurt people. And me and you have had this conversation. Therapeutic hypothermia, things like that, right? We need to use the data that we have available to really think ahead for what's going on for care. I don't know if I was all that controversial on that, Sarah.
I think that's why I brought it in, because it didn't need to be as controversial as I feel like social media is making it out to be. Okay,
fair enough.
The second big one, and this one intrigued me, was dual or double sequential defibrillation for refractory VFib or VTAC. What led to the committee's decision there, and what should clinicians understand about the strength or limitations of the evidence for double sequential defibrillation?
Ooh, that's a great question. And literally, me and you should come back and do another hour on this. No, I mean, serious, because I did a bunch of podcasts for others talking a little bit about double sequential defibrillation when it first came out as dose VF study, right? I think that's the first thing. So I'll be honest with you, I drank the Kool-Aid. So my agency, I'm actually one of the early people who published on doing double sequential defibrillation with Columbus Fire. So if you go look back at the history, I am one of those guys. And Dr. Cheskis is a great friend, and I think he's done amazing work. So now the question is, what is double sequential defibrillation and what does it really mean to us, right?
Hey guys, real quick to interject. So I realized while editing that we don't actually explain dual or double sequential defibrillation, DSD we call it. So I wanted just to explain it really quick in case you haven't heard of it before or seen it done in practice. So you all know that we can use defibrillator pads with two different placement options, either anterior, posterior, so one like center of the chest in the front and kind of on the scapula on the back, or anterior lateral, so one on the upper right chest and the other pad kind of underneath the heart on the left side. Both pad placements allow you to kind of sandwich the heart in between the two pads. So the idea with double sequential defibrillation is if you've been defibrillating a couple times with one vector or one type of pad placement, either anterior posterior or anterior lateral, and you're not getting the patient to convert out of the ventricular arrhythmia, the double part is where you grab a second defibrillator and a second set of pads, and you put the second set of pads on the other vector. So if you already have it anterior lateral, you're going to now place a second set of pads anterior posterior. So now there's literally 4 pads on the patient total, each set attached to a separate defibrillator. And then the idea is that from 2 different directions or 2 different vectors, we're going to defibrillate almost simultaneously. So myself, say, and another person both have fingers on 2 different defibrillators, and we count down 3, 2, 1, shock. And there is some literature that shows that patients might actually come out of this arrhythmia from the double shock. However, it wasn't quite enough impressive literature for the AHA to make this as a recommendation. But if you think about that, if they were to make that as a recommendation, what would that mean for every ambulance, for every hospital floor? So huge ramifications for every decision the AHA makes when it comes to their guidelines. So, all right, back to the podcast.
So I think one of the fundamental challenges that we have, and notice I'm not talking about vector change. One of the fundamental challenges we have in the dose VF trial is, what are we really looking at? Is it incessant VF that we shock and it stays in VF the whole time and never comes out? So it's truly refractory. Or is this truly recurring VF? So in my experience, I've used it. I have people who've broken, right? I've had people who've broken. I can't honestly tell you, did they break because this was recurrent VF that now I just finally broke it? Or is this incessant VF that's been continuing on and the DSD now broke it? In the guidelines, we talk about a detailed analysis where they looked at the proportion which may have been in those 2 different categories, right? And it looked like the incessant is only 17%, whereas the recurrent was more. It brings a lot of questions into what we're thinking about here, right? So it pushes us to start thinking about, are we managing 2 different disease processes with one intervention without knowing exactly what we're doing with the intervention, or what's the process? Now, add to that some of the challenges of the trial, right? So these are the dirty little secrets that we have to think about, right? It's that the trial had to be stopped, right? The trial got stopped because of compliance, that the EMS clinicians were maxing out, right? They were at their point. And there are different characteristics of that when you're not making the power of your study that you have to take into consideration. Now, here's the good news.
Hey guys, I just wanted to take a quick break to talk about something that I think is really important, and that is getting certified in your nursing specialty. Not because having the extra letters behind your name make you a better nurse, but because taking the time to deep dive into all that you need to know for your specialty, putting in the study hours, and dedicating yourself to mastering what your patients need you to know how to manage them best, the prep for the exam, is what will make you a better nurse. So whatever specialty you are currently working in, Go study for that certification exam. And if you're a critical care nurse, I have something that will help you pass your CCRN. My friend Nick McGowan has an excellent online self-paced CCRN prep course called Critical Care Academy. It is so thorough, and he has broken down everything you need to know into little bite-sized digestible content that he calls micro-learning. Let me tell you, the CCRN is the hardest test I've taken in my entire life. You don't want to go it alone. You want to take this course to ensure that you know your stuff before sitting for the exam. If you'd like to check out his course, you can find it at ccrnacademy.com. And great news, just for being a Rapid Response RN podcast listener, you get 10% off the cost of the course by using the coupon code RAPID10 at checkout. So, if you've ever considered getting your CCRN, do it. And let Critical Care Academy help make sure that you will pass. I'll put the link and coupon code in the show notes.
Right? The good news is we know there's other randomized controlled trials coming. So we don't have to know today, right? Now, on top of that, how many people are affected by this? Well, that's the other question, right? If it's truly incessant that we're going after, that means after 3 shocks, our population is getting smaller and smaller and smaller because we're starting at 17 to 20% of people in a shockable rhythm. Then we're getting down to what? 2, 3%? We're getting smaller and smaller and smaller. That knowing the answer is going to be important for us, but it's also a small impact in the vast majority of cardiac arrest is a lot smaller. Now, last but not least, one of the things that I want to bring back is actually understanding what the answer means and what's the implications of those answers, right? So one of the things that I thought about when we talked about DSD a lot is if I said today, we should use DSD, what are the implications going to be? I mean, Sarah, what do you think would happen if I said today, everyone should do DSD? What would happen? The companies would go crazy, right?
Yeah. I mean, they would make a lot of money because now every EMS rig has to have 2 defibrillators and every nursing floor has to have 2 defibrillators and everywhere has to have double the amount of equipment. They would love that.
So we have real implications by what the American Heart Association distinctly says is right or wrong to not only all these hospitals, these EMS agencies, but all of clinical care. And so now we have a bigger question here. If we have doubt, we need the answer, right? And we need to clarify what that answer looks like before we make that large of an implementation need, right? So I think one of the things that we really need to think about is what those implementation concerns could be. And I think we have lots of examples. Heads up CPR, right? That's a huge example, right? And ILCOR came down hard on that. And you guys probably saw that in the guidelines. There was no question where everyone said, this needs to be done in clinical trials. No more playing with people's lives. Let's do this in an ethical manner such that everyone knows exactly what we're doing, right? Mm-hmm. And I think this is one of those areas that more and more, as we think about writing groups and what they think about, especially in the realm that we are in a group of experts who have lived through therapeutic hypothermia, who have lived through a lot of these different things, we're really looking for the answers. And we're really looking deeply into the data to get a good answer. And those answers have real implications about care. That's a powerful statement. And I think that's one of the things that a lot of us keep up at night when we think about what recommendations we're going to do.
That's a huge responsibility, but also a privilege, right? To change practice for the better. Yeah.
It's super cool. Yeah.
So the next one, and this is kind of a minor thing. It seems like a small detail, and that is IV versus IO access.
Yeah.
It seems like nothing, but in a bunch of chaos, it's a big deal. So What is the AHA recommending with regards to IV versus IO? And can you walk us through the rationale for prioritizing one over the other? I'm just curious your thoughts on that because I have opinions, but I'm curious your thoughts.
Well, I think it comes down to randomized controlled trials, right? I mean, I think that's what it comes down to. You had 3 randomized controlled trials, which really looked at this question. Some of them weren't as good as others. I mean, that's just the nature of studies. Sometimes they're good, sometimes not the best, but they definitely informed us of what we needed to do. And from that data, IV came out superior over IO in the sense that we know we're getting better and more stable drug levels and all those kind of different pieces. It's also consistent with what we've been doing, right? It gives us a lot of focus on what we can do. And it's going to be interesting because I think the more we talk about this, even when we think about the evolving literature, there's evolving literature that people are starting to look at IM care, right? In skeletal muscle. If I inject somebody, is that going to depot enough so that it's going to be a good delivery system. And people are talking about this and people are doing observational work around this space. And so I think one of the cool things about this is it's really starting to inform us a little bit bigger that having that IV could actually help us in a lot of different ways, and really thinking about what becomes the bioavailability when we actually have something which is intravenous, which can make it into interstitial spaces, but actually can move around, versus something which is starting in the bone or an interstitial space, and what that impact is. And so I think it's kind of exciting, especially if you read that section, that it goes through all the trials and kind of talks a little bit about that. That makes it a little more fun to look at.
So you had said you drank the Kool-Aid with regards to double sequential defibrillation. I have drank the Kool-Aid with regards to IOs. I love IOs, especially as a rapid response nurse. I can just like jump in there left-handed across the bed, throw one in. Like I've gotten really good and really fast at them. I don't have to think about it.
Yep.
And granted, if I see a giant pipe, I can start an IV. But most patients in cardiac arrest have lost all of their vascular tone and they're just flat.
Yeah. They got nothing.
So, okay, I noticed that the European guidelines actually gave clear recommendations for attempt IVs twice and then go IO. And the AHA kind of left it vague, like you should prefer IV versus IO.
Yes, and that was purposeful.
Oh, I know. But like when in the nitty gritty, I'm in a code and I can't get an IV. How long do I wait and delay medication administration before I say, okay, I'll do the lesser option and go IO?
I wouldn't. My opinion, and exactly what was written there, I would give it a shot. If I miss, IO.
Okay.
Right? Because keep in mind, I want to tie this back to some of the other guidelines that we have in there is early epi.
Right.
Right? So when we looked at Paramedic 2, the delayed epi still had benefit. And we know that early epi would be very powerful. We don't have that trial. But like if we think about the concept that we want to get early epi especially for our non-shockable rhythms, man, there's no question that you got to jump in there and make it happen, right?
Yeah. Okay, so to wrap this section up, before we get to epinephrine, the big one I want to talk about, for the teams that have been using double sequential defibrillation or mechanical CPR devices like for everybody, how do they reconcile their local protocols or practices with what the AHA is giving guidance towards?
Sure. I think mechanical really doesn't change, right? The guidelines have been the same. So I think you should definitely look at your protocols and think about safety versus not safety and really start weighing the benefits and risks of what you're doing with a mechanical CPR device and the potential benefit for the clinician versus the negative impact on the patient. I think that's what it comes down to, right? So you're going to have to look at your protocols and make some serious considerations on that. When it comes to DSD versus vector change, this is one of those things that you really need to think about and think about your patient population, right? There are some groups who are doing DSD as the first shock for every single arrest. I know.
Wouldn't that delay the first shock trying to get double pads on?
Well, not if you have it on a fire engine, which is right there, right? So especially if you have two different things coming at the same time to a scene, right? So you have the potential, right? I think that seems kind of ridiculous. And even at the third point, if you're going for the third one and you haven't changed vectors or something like that, you definitely need to start thinking about that. I think one of the big things, especially around DSD, and our shop has both DSD and vector change as part of my EMS protocol. And so we're having this discussion ourselves is should we be maintaining this? Should we be taking it out of our protocol or whatever the case may be? And essentially what we're saying is it's not ready for routine use in all these situations without clarity, right? And that more evidence is needed. And you can be part of that evidence, right? And you can be part of the work that has to go into trying to figure that stuff out, right? For our work, I think more and more, I think we're realizing that one of the key things we need to think about is optimizing the whole front end of what we're talking about, right? So when we're talking about DSD, we're talking about 2 shocks in, really, and that is now from 17% of our population down to at least 3%. We're going further and further because this means somebody has to stay in VF, right? So again, it's going to be a small population of people, but you're going to have to really weigh the benefits of actually having that much equipment available, the cost of that, and what that means for your patient population. And actually, the best part is if you are looking at your data and you actually have data looking at this, that's probably where you should start. If you're not looking at any data, you shouldn't even be thinking about this, to be honest with you. But if you are looking at your data and you can see the number of patients who are impacted by this, that'll give you some guidance about what kind of risk-benefit decisions you need to make.
My general take on these things is that And I feel like AHA was doing this in the way they wrote the guidelines. I feel like you're saying, this is my words. Guys, could we stop looking at all the shiny toys and just get back to the basics of high quality CPR and ventilations that are actually making the chest rise and fall?
You didn't miss the message, did you?
Can we just focus on the stuff that we know works and don't get so distracted on this expensive things that seem fun and cool and sexy? We know CPR works. Get the hands on the chest and do it well. That's how we're going to save lives. So that's kind of my take on mechanical CPR versus, there's so much debate, but just do good quality CPR as fast as you can get your hands on the chest. That's what's best for your patient. Okay. Final big question for you. The question that every resuscitationist wants to know, and that is about epinephrine. Okay.
It hasn't changed.
I know. It hasn't changed. I think that is the concern. Sure. So there are some studies that are suggesting that our standard epinephrine, 1 milligram every 3 to 5 minutes, even though it improves ROSC, it might worsen neurological outcomes. And the guidelines...
Oh, Paramedic 2 said that flat out.
Right. And the guidelines didn't change the dose or frequency. So I guess the question is, what was the conversations where you guys said, no, we're going to keep things as is versus make modifications? Because honestly, I was expecting maybe the dose changes after a couple doses, or there's a max dose, or we titrate based on entitled. I don't know. I thought something might be modified with the new guidelines, but it's exactly the same as it's been. So I'm just curious what happened behind the scenes, how we came to that decision.
Well, I guess the question is, what evidence?
I know.
Right? So I think that is the crux of it, is it starts with what evidence, right? So let's start by going back to Paramedic 2.
Okay.
Because I think that's where all this started, right? Paramedic 2 is a great trial. Do not get me wrong. The people who did it did an amazing job for a very, very difficult disease process. And when we think about what they did against the Australian trial, which was killed, right? But this is a great story when we have time, is the Australian original trial on epinephrine was killed by public opinion. And that's how it was devastating, right? And they never made power because they had to stop the trial because public opinion basically said, you're using our people as guinea pigs. Horrible, horrible, horrible situation. Anyway, great historical discussion though. So when we think about Paramedic 2, the outcome was very clear when it came to the concept that, there looks like there might be a little bit more neurological poor outcome for patients of those treating the epinephrine group, right? Now, keep in mind, when we think about the Paramedic 2 trial, the way I like to refer to it as, I always refer to it as delayed epinephrine, right? Because by the time you look at the time to first epinephrine, it's almost 15 to 20 minutes, right? It's crazy. It's something that if I happened at my agency, I would be on the phone with my medics saying, hey guys, what happened here? Tell me about it. Let's break this down. Let's work on this, And it was interesting because there's always challenges in every system, right? And so we have to recognize that it's not exactly our system, right? And so when we think about that concept of delayed epinephrine, we have to understand that means also delayed brain, also injured brain, right? Now, classically, when we think about this, and the best next thing to look at is, I believe his name is Holmgren. It's the systematic review, which put together all the epinephrine studies and looked at the details. It proved one basic concept, that for our non-shockable rhythms, there is nothing else which improves outcomes except for epinephrine. Right? So that's powerful, right? So if we can powerfully say for non-shockable rhythms where we had nothing else before, and now we have something that will actually help bring somebody back. If we're doing good CPR, we can keep them neurologically intact, and we do early epinephrine and we can get them back. That's something. That's something that we didn't have before, right? Interestingly enough, as you would expect, epinephrine was not as effective for shockable rhythms because we have defibrillation. That's what's saving those people. And now we have something for the other place. But when all is said and done, and we said this, I think, in the guideline, and I can't remember how the words we used, is there's no way we can talk about neurological outcome if we can't get ROSC. If we can't get ROSC, what are we doing, right? And sure, I agree. Epinephrine at the dose that we have, we're going to need to look at this. But there's no dose response studies for epinephrine right now. So we have no guidance to know where to go. We do know one thing. Actually, sorry, I misspoke. We know high-dose epinephrine kills people.
A long time ago. I remember those days. A little purple vial, like
bam, bam, bam.
The brown purple vial, remember? Oh my gosh, we gave so much epi.
Oh yeah. And we know that we can give that to a rock and the rock will start beating. But the point is that we know that high end is bad. We have an idea that there's cumulative amount, which is probably bad, but we don't know what amount. So there's a lot of questions, right? And I think one of the things that we're stuck with, even as guideline writers, is the evidence. Where's the evidence, right? How do we make a call on this? Especially when every life matters, right? So truthfully, when you're at a survival rate of 10%, 11% in a community, and your neurologically intact survival is 6 to 7%, making changes that could hurt people without data becomes something that you're just like, oh God, because every percentage point matters at this point, right? And that becomes a really daunting decision-making process. And so in a real sense, without the space of evidence, without something giving us guidance, it's really hard to make that change because you have no framework to say that this is right or this is wrong. At that point, it becomes, Sarah, you and me sitting around and saying, hey, this is my opinion, and my opinion's better than yours, and this is what we're going to go for. That's scary, right? That's just kind of icky at the same time, right? Because maybe my opinion is, I don't know, half crazy. It's possible. So, I mean, I think leaning on the evidence on that definitely gives you a framework. One thing that does to this day, I think is one of the most important things that we've done as AHA, and this was in 2020, and I'm so proud to be part of this, was making the chain of survival for survivors, to show that we actually have survivors and really respecting the importance of those survivors. And I think as we start talking about epinephrine more and more, I think the concept of following neurological outcomes as our outcome variable in a lot of our trials, and you're seeing that as a whole focus, has really highlighted the importance of what we need to do. But I'm very intrigued to see these dose response type studies, and they're coming. They're coming, and they're going to be very informative about what we're supposed to do. And it would be crazy if we just stick with, I mean, gosh, 20 years from now, we really should not be still on the same epinephrine dose.
But like you said, we can't even talk about better or worse neurological outcomes if we never get to ROSC in the first place. So let's keep doing what we're doing.
And one last thought on that.
Yeah,
Sorry, Sarah. One last thought is keep in mind, Paramedic 2, when it was done, randomized epinephrine, but did not standardize post-ROSC care. Just think about that for a second. They randomized epinephrine, but did not standardize post-ROSC care. So temperature control, all these things, early angiography, a map of 65 for hemodynamics, none of this was controlled. And we have no data on those patients afterwards. So we actually don't really know what happens from the moment of ROSC through to neurological outcome. So we still say they're devastated neurologically. And if we say it's all due to epinephrine, we actually don't know. It's kind of scary.
I look forward to the future research for sure. Okay, Let's wrap this thing up. Let's talk about how all of this translates into real life. Because for our audience, the question is always, okay, what are you different tomorrow? So from your perspective, what's the most important change that these guidelines that nurses need to apply? What do they need to understand right away?
Okay, so the most important thing that I think all of you should do today in getting ready for Thanksgiving is get one of these stupid CPR anytime kits. They're like $20. Get one, bring it.
Oh, I have one.
Yeah, bring it to Thanksgiving dinner.
Oh, I love
I'm sorry. I am that guy. I'm going to be that guy to the end of my days. Everyone in my family knows I am that guy. And please, please, if you think you want to be truly an insane resuscitationist, bring a mannequin to Thanksgiving dinner, because then you throw it on the table and say to everybody, hey, who doesn't know how to do CPR here? Everyone's going to be like, oh, I know, you're an idiot. Why are you doing this? Blah, 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 blah. But in fact of the matter, so many of them just seeing the mannequin will have a new perspective on the reality of life, because you can say one line to them, say, you know what? Greater than 75% of all cardiac arrest events happen in the home. And the person who you save could be your loved one. It could be your aunt, your mom, your dad, whatever the case may be. So if you're going to do anything this time for Thanksgiving or Christmas, do that for me, please.
I love that.
And I'm going to get to the other stuff in a second, but honestly, that's where we have to start. Because the very fact that we cannot get CPR to everyone who needs CPR is a travesty. And if you look at the data in Denmark, who have 80% bystander CPR rates, we can do it. It's just having people who have the intention to do it. And we need to change the intention framework. So first thing, okay, that's the first thing I want you all to do.
Okay.
When we think about the overall care that we provide when it comes to resuscitation in general, I think the engagement that we have to really coordinate as teams becomes critically important. And you're going to see that in a lot of the products coming out, right? Is really talking about teamwork, how we work as a team, how we coordinate as a team. A lot of you out there are great high-end resuscitationists who are already doing this in your hospital. Keep it up. Because one of the things we do know is that is a big part of getting those resuscitation outcomes that we want. So team coordination and working together around our cycles. That's what gets us to early epinephrine. That's what gets us to high performance CPR and early defibrillation. All those key comments. I'm going back to what Sarah said earlier, so I'm not really all that surprising. Do the good things that we do well. Just do it, right? I think then we have all our IV and IOs and all the medications we're using our higher doses of shock when we need for cardioversion. I think all of that's good. All of that's appropriate. I think using the techniques that we know work, right? Use the directions that we know work. And I think that's where we start, right? Then the fancy things are going to come. Then ECMO is going to come. Then we're going to be able to pinpoint the people who need these kind of interventions. Now, one thing I do want to point out though, is for all of you out there, look at the ETCO2 section of the guidelines. Okay, ETCO2, right? How many of you are actually using ETCO2 to guide your resuscitations and really start using that? You can use it for your great bag valve mask if you're actually having a really good seal. Definitely supraglottic, definitely ETI. That's going to guide a lot of your resuscitations, give you guidance. I will tell you, my strong belief is that is going to become one of our strong physiologic markers over time about what we can do to better resuscitate people and make decisions about who is resuscitatable. And that'll come. And so definitely pay really close attention to that. Post-arrest care. Got to make that a priority, right? As the door, we're all cheering, we're all happy we got the ROSC, but gosh, you guys got to engage in that post-arrest care and really demand the time period that patients need to get out of their funk, get out of their coma funk, so that we can actually make good neuroprognostication, because there's people we can bring home to their families. Last thing, sorry, I'm belaboring. Last thing.
No, I love this.
For our survivors, for the people who make it, set up discharge instructions. Set up outpatient care, set up a whole manner of which the armies of people who already exist are engaged in making sure this person gets everything they need. Because this is a success story, and this is our loved one who's made it home, and they may be neurologically intact or they may just be short of that. But the problem is, one of the challenges that we have right now is so many of our survivors go home without real care planning, without a concept of who they need to follow up with, without actually having all the pieces and tracking where their neurological outcomes actually going, right? So make that one of the big hallmarks of what you do. That's my soapbox, I think.
I think you covered all the things. I can't think of anything else I want to talk about. Are there any other misconceptions or things that you've heard on the internet that you want to clear up before we close today?
No, I think this is most of it. I mean, I think when it comes down to us, as all of us as resuscitationists, I think we own this space, right? We own this space together, right? And I love the comments in the blog sphere. To be honest with you, I love it. And why do I love it? Because I soak it in. I hear the response because it sets up the stage for the next study. Mm-hmm. It tells us, okay, people don't understand this, or this is not clear enough. This is what we have to work on, right? This is good. These arguments are powerful. They're great. They move us forward, right? But one of the things I want you guys to do more and more, especially as resuscitations, look at the papers. Go back and read some of these crazy articles, because then you can see the cool stuff. Like, I'll be honest, Sheldon's paper on DSD, the dose VF, is fantastic. The commentaries are fantastic. There's a great bunch of different things all about that space, which is so exciting because it really is this moving target that we're learning about. And you'll see how science develops and how this exciting moment happens in our time. And this is our time. And this is true about temperature control too. And it's an exciting time to be a resuscitationist. Just live it up and be part of it. I think that's probably the best thing I can say.
Let's never get stuck in old dogma. Let's keep pursuing the new evidence and do what's best for our patients. At least what we know now is best for our patients. I'm here for it. When you get to shake the hand of a patient who you did CPR on, that is the coolest experience and worth every bit of research and literature reading and like all the time I put into, not just at the hospital, out of the hospital, it's so worth it when I get to see the outcome of like, we got to save a life. What a privilege. So I think this conversation really highlights how much goes into all these updates. Obviously, 5 years of meetings and research and reviewing the literature, but it's not just reviewing the data, but interpreting it responsibly, thinking about how it impacts real patients and systems as a whole. So to recap for our listeners, the new AHA Resuscitation Guidelines, they bring some welcome clarity to algorithms, some better guidance, especially for post-ROSC care. But as Dr. Panchal explained, there's still some areas that could use some more research, and we are excited for them, right? We're going to keep evolving as the research comes out. I think the key takeaway is this, that guidelines aren't just about the rules. They're about reflecting the best available evidence at the moment and helping us make better, more consistent clinical decisions when every second counts. So Ash, thank you so much. Thank you so much for taking the time to join us, for your incredible work in this committee.
My pleasure.
Let's keep resuscitation science moving forward.
I love it. Thank you so much for having me.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.